Does he have to say next slide or?
Sorry, I missed that then. I was recording.
Just say next slide for the slide control.
Yes. All of you just, do a Boris and I'll just move the slides along. If I just start screen sharing now, just to make sure you can all see. Can you all see that?
Yeah.
There we go. It's not broadcasting yet, so it's 1 minute to go. So yes, at 1 o'clock, if you can just start the webinar. And if you all want to mute yourselves and turn your videos off.
I actually can't see my clock now that you've shared your thing, Charlotte, so I'll assume that it'll just...
I can see it, so I can start. That's fine. You can see all the poll stuff at the bottom, yeah, Jess?
Yeah.
Great. Fantastic. I'll give it a minute. And then you should see, once we've clicked start, you should see people, the participant numbers should start going up, then you'll be able to see people join in, hopefully. Just go. Just making sure. Right. Okay, I will click start webinar and then we should, fingers crossed, see everyone join in. Good luck.
Good luck, folks.
Good afternoon to everyone coming on. We're just going to wait 1 minute while everybody gets the opportunity to log in to the start. I think we're quite pushed for time, so I'll just start on some of the housekeeping stuff. Good afternoon to everyone logging on this afternoon. Welcome to our first Community Oncology webinar. I'm Charlotte Stevenson and I'm a Business Development Manager at Cardiff University, and my function here today is just to support the team with this fantastic webinar series. A quick few housekeeping before we get going. We've got the chat function available at the bottom if you want to talk to the team, any sound issues or anything like that. We've got the Q&A there. If you've got any questions about the content as we're going along, pop them in the chat and we'll make sure that we ask our lovely speakers today. We're all working in different locations, some at home, some in clinic. So please bear with us if there's any interruptions, any technical issues or any comedy talking on mute. And in order for us to keep going with this kind of free webinar series, we really do appreciate any feedback you can give us. So there's an opportunity at the end to complete an evaluation form. That's enough from me. So I'm just going to hand over to the fantastic team.
Great, thank you, Charlotte. So welcome everybody. I'm Fiona Rawlinson. I'm a reader and postgraduate director for the palliative medicine courses, and myself and Elise Lang and Mick Button ran the first short course for community oncology 2 years ago. And this time last year, the repeat session actually was one of the first casualties of COVID, because everybody this time last year, as you will I know remember, was very busy planning. So we're really grateful to Charlotte and the team to be able to reimagine community oncology short course and be able to have these series of webinars. We're very tight for time. Inevitably, there are going to be questions that things that you might want to know that we haven't got time to answer, but please use the question and answer and the chat, and we'll try to get as much information out there as we can. Just as we start though, it would be really helpful to know who is on the call today. So we've just got 2 polls, just really to give us a feel. So could you just tell us what your main role is? So are you out there in the community? What your role is? Are you a nurse, an allied health professional, pharmacist, etc.? Do just give us your feedback. That would be really helpful. And Jess, you're in control of the information buttons. So wonderful, fantastic, thank you. So predominance of GPs, GP trainees, but other people joined us as well from all sorts of different backgrounds. So thank you, that's great. And we've got 1 more poll to go, just to give us a feel for who's here. I hope. So Jess, have you got the second of the questions? Would be great. It's just really...
Just having a bit of an issue with it at the moment, Fiona. I'll try and get it up now.
That's quite all right. We'll have one more go, and then we may have to ask you, if we can't do it, just to put something on the chat. Wonderful, wonderful, wonderful. So where are you from? If you could let us know. Everybody's welcome. All roles are welcome. Some of the information may be a little bit specific to Wales or our area, but have a think if that's the case. What do you know about what happens in your area? And how some of the information from the webinar today, will that make you, I hope it will, make you go and just seek information from more locally to you. So just let us know where you're from. That would be really helpful. Predominant Wales, but a smattering from everywhere else, and the somewhere else people, would you mind just pop in the chat where you're from, because we're fascinated to know who's joined us. I think, thank you for letting me set up the themes for the day, and I'm going to hand over to my colleague Elise. Thanks, Elise.
Thanks very much. I'm Elise Lang. I'm a GP in Cardiff. I'm also the Macmillan GP lead for Velindre Cancer Centre, and as Fiona said, Mick and I have been working with Fiona and Cardiff Uni hosting these full days previously. But in COVID times with remote working, we're trying this 1 hour sessions in hopefully your lunch break to try and update you with some of the changes with cancer services locally through COVID and current climate. So in primary care particularly, things have changed overnight in the last year, as they have in a lot of medical fields. We no longer really see that many patients and are dealing with an awful lot of consultations over the phone. And so some clinical signs are going to get missed. The opportunity to do physical examinations is more limited. Some of the referral pathways for some of the cancers have been rewritten, particularly locally, in light of sort of exposure risk and seeing patients. And certain new things which were on the horizon have been brought in maybe faster than expected, things like fit testing and things. So it's with great pleasure we've got three great speakers today. But first of all, we've got James Horwood, who's one of our local colorectal surgeons in the Heath Hospital in Cardiff, talking about the journey from primary care into secondary care when we're concerned about patients and what screening and referral processes are like currently. James.
Brilliant. Well, thanks very much, Elise. And it's fantastic to have this opportunity to interact with primary care and people working in the community. I'm just going to talk today about fit testing, which I know because I've had an awful lot of emails from primary care. A lot of you know about, and I'm going to talk about how fit testing is going to be embedded in our lower GI USC pathway recovery going forward. Okay, Charlotte, next one, please. So this is just a very basic graph that shows what's been happening to our USC lower GI referrals at Cardiff and Vale over the last 6 or 7 or even 8 years. Basically, we're getting about 200 to 300 more USC referrals every year. But interestingly, the incidence of colorectal cancer is not changing. We are investigating more and more patients, but we're not diagnosing more colorectal cancer. That's lots of very clear reasons for that. We've got an elderly and aging population. I think there's a lot around patients as they get older still want to be fully investigated for their symptoms, so their expectation is changing and putting a lot of pressure on primary care probably for referral. And there maybe is a bit around becoming more litigious society. But what it does mean is that there has been, over the last few years, a huge increase in the pressure on our diagnostic services. And in colorectal cancer investigation, we're really talking about endoscopy or colonoscopy and to some extent CT scans. And so our system of diagnosis, even before COVID, was really creaking, if not starting to break. Next slide, please, Charlotte. This is a slide from 2017, and I just want you to look at the Wales number and the first bar for Wales. This is the bar that tells you how successful we were in hitting our targets for USC lower GI referrals. And as you can see, in 2017, less than 60% of the USC referrals which we received in Wales, we actually managed to investigate in a timely fashion on the USC targets. So in 2017, a little bit more evidence that our diagnostic services were struggling to cope with the workload that we were being sent. Next slide, thanks, Charlotte. Also, on the background of what I've just told you, this is what was coming. Screening was due, bowel screening obviously, was due to drop their screening age to 50. Now, what that means in Wales as a country, that we were going to have to do per year, we were going to have to increase, sorry, per year from 2,000 colonoscopies to 12,000 colonoscopies per year for the screening population. So, on a picture of a background of a USC pathway which was creaking at the edges, we were there going to have to find another 10,000 colonoscopies per year in the country. So clearly things were going to have to change. Next slide, thanks, Charlotte. And in Wales, there has been a chronic, I think it's reasonable to say, a chronic underfunding in endoscopy services. And we know that we have one, per capita, we have half the number of endoscopy theatres as they do in England. So we also have less capacity in Wales. And then, of course, our old friend COVID hit. Can you pop the next one? Thanks, Charlotte. So this is what happened in the first wave. So almost a year ago now, our endoscopy capacity fell to almost nothing. And we rapidly introduced fit testing into our pathway. So essentially every USC referral we received, we sent a fit test. In the first lockdown, we had 46 positive fit tests, and those patients we sent for colonoscopy. So we had very limited access, but we did have some. And over those 46 patients, we found 4 colorectal cancers. Almost the more interesting group is the people who were referred on a USC pathway, but were fit negative. Actually, in that group, and we followed them up to about 7 or 8 months as we are now, we've diagnosed some other conditions. But to my knowledge, and with limited follow-up, we have not found any colorectal cancer in patients who were referred on a USC pathway, but were fit negative. The most important part from this slide, for my talk, is the 186 colonoscopies which we have avoided. So pre-COVID, we would have had to done an extra 186 colonoscopies in this patient population, but because of using fit test and because of the pandemic, we actually have hugely reduced the reliance on colonoscopy for investigating lower GI USC referrals. And the early data from bigger studies suggests that if you use fit test appropriately, then you can reduce the requirement for colonoscopy in USC referrals by 70%. So that is huge if I put that on the background of the picture I painted of the system before COVID came along. Next slide, thanks. So what is fit testing? Well, very basically, fit testing is a posh fecal occult blood testing, I think of it as. It's actually more sensitive and specific for detecting human hemoglobin in the feces. It is more specific than FOB for lower GI bleeding, and patients don't have to change their diet in the 2 or 3 days before sending off a test. But most importantly with fit testing is it's much better tolerated by patients. It seems that the way you collect the sample is more acceptable to patients. And in studies across the UK and studies around the world have shown that fit testing results in more return of samples from patients than other ways of testing stool. Next slide, thanks. This is the one study that everyone is talking about, and the only study I want to talk about is from Nottingham, where they took 10,000 consecutive patients who were all going to be sent for a USC colonoscopy. They still did the colonoscopy, but they also did a fit test. And all they did was correlate the colonoscopic findings with the fit test findings. And the key outcome is this: if you have a negative fit test, the chances of you having a colorectal cancer are extremely small. So just to be clear, that's if you have a negative test. You have a very small chance of having a cancer. You can have other pathology, granted, but you're very unlikely to have a colorectal cancer. Now we have to compare that to colonoscopy, which is considered the gold standard. And we know that around the world, we miss colorectal cancer when we do a colonoscopy. And that rate runs at about 3 to 8% miss. So the rate of having a colorectal cancer in the 3 years after having a normal colonoscopy runs at between 3 and 8%. So that is, if you like, is the false negative rate for a normal colonoscopy. And you see how that now compares with a FIT test for excluding colorectal cancer. Next slide, thanks. Well, what about the money? Everyone talks about money. Well, actually, a colonoscopy is £440, a CT is £250, but a FIT test is only 12. And so on every economic model, when you look at FIT testing in the USC colorectal pathway, FIT testing will always win because you don't need to avoid many colonoscopies to make FIT testing worth its weight in gold. Next slide, thanks. So this is a situation for referral to the Cardiff and Vale lower GI USC pathway pre-COVID. And actually, there was 3 different routes. In primary care, you could either send a patient to the colorectal USC pathway, or you could choose to go via gastroenterology, or you could send for a directed test USC radiology. Now, the problem with this is that we all had different ways of investigating the same complaint. Some of these patients were being tracked and reported to Welsh Government, and some were not. So we've decided that actually we want a single point of entry for lower GI USC referrals to our health board. Next slide, thanks. So along with the gastroenterology team, we've come up with a Cardiff FIT pilot study, and it has obtained funding for 6,000 FIT tests from primary care. It is going to include USC patients, but also what is known as DG30 patients. Now, these are the patients, if you're not aware, who have significant bowel symptoms, but don't quite fit the NICE criteria for a USC referral, yet nevertheless should be investigated. And we're going to follow these patients up for over a year to see how FIT test is embedded into the pathway. Charlotte, next slide, thanks. This is probably the most important slide of my talk for the audience. What is going to happen, and is almost live, is that if you sit and you have a consultation and you decide to make a lower GI USC referral, there is an online portal, a new one, which is being rolled out, which takes 2 minutes to complete. And when you press the send button, that will automatically send the patient a FIT test, and you do not have to do that separately, and you do not have to wait for the result. The patient will still be referred to our service on a USC pathway. That referral will then be triaged by the team at UHW. And if there's a palpable mass, if there's obstructive symptoms or iron deficiency anemia or rectal bleeding as a predominant symptom, the patients will be sent straight to test. We will be looking at the FIT test more as a research tool. However, the patients who are over the age of 60 with change in bowel habit, and this actually encompasses the vast majority of these patients, we will wait for the FIT test result. Now, it does depend on how quick the patient is at returning the sample, but if they return it by return of post, we get the answer within 7 days. If the patient is FIT positive, they go on and have a USC colonoscopy. If the patient is FIT negative, this is a very interesting group actually. We know that yes, they may have symptoms, but they are very unlikely to have colorectal cancer. So what we will be doing is taking them off the USC pathway and sending a letter back to the referrer and also to the patient. And what we're suggesting is that there is a safety netting in place, that the patient, maybe if their symptoms have deteriorated or not improved in, say, 6 weeks, to seek further advice in primary care. What happens then is we will be directing or recommending that we use the health pathways system for further investigation of these patients on an urgent rather than a USC basis, therefore preserving our finite resource for those patients most likely to have a positive test. So next slide, thanks, Charlotte. You got the next slide there, Charlotte? Great. So this is the pathway now for patients who don't quite achieve the NICE USC criteria, but still have significant symptoms. These patients, you will also send off a FIT test, but then wait for the result. If the FIT comes back positive, then they will be taken on as a USC referral and they will have an appropriate investigation. If they are FIT negative, we know again they are very unlikely to have a colorectal cancer. And depending on their predominant symptom, if I take the example in this slide of diarrhea, we will be directing primary care physician to go via the health pathways system, and pathways have been written for all these conditions for further investigation and management of those specific symptoms. For diarrhea, it'll be things like fecal calprotectins, maybe fecal elastase levels, thyroid function tests. And at some point in that pathway, depending on how it's been written, will be referral to secondary care, but on an urgent rather than a USC basis. Next slide, thanks, Charlotte.
Sorry, it's been a bit of slow. Bear with me.
Okay.
Is that it?
That's the one, yeah. So this is just a screenshot of one of the health pathways. I've taken this from the gastroenterology section, and if you're seeing a patient with dysphagia, for example, you'll be able to click on the health pathways dysphagia section, and the gastroenterology team have written a flow diagram for the investigation and management of dysphagia, which will include referral on certain pathways depending on certain symptoms and tests coming back. So the whole idea of this is that we can, prior to COVID, we had to do 30 colonoscopies to diagnose one colorectal cancer. The early data would suggest that by using FIT tests in the appropriate setting, we only will have to do 4 colonoscopies to diagnose one colorectal cancer, which is a huge benefit, not only for the patients who have got colorectal cancer, we can prioritize their investigations, but actually means we will stop doing unnecessary colonoscopies in a large number of patients, which is also quite important. So final slide, thanks, Charlotte. So I think my final slide just is saying thank you very much for asking us to talk. FIT testing is clearly the future for the investigation of USC and non-USC symptoms. And this is how we are going to start embedding FIT testing in our pilot study. And obviously it will depend on the results of the pilot study, but we imagine that FIT testing will be a huge part of USC referral patterns going forward in one form or another. Thanks very much.
Thank you ever so much, James. That was a really clear and succinct summary of where we are now with referral processes in Cardiff. Just to be clear to all the attendees today, there will be a question and answer session at the end, and the 3 speakers are going to stay on for that, but obviously have clinics to go to at 2, and this webinar will end at 2. So if possible, if you could put questions up on the chat or the Q&A section, sorry, as we go, Fiona can kindly summarise those and sort of minimise the time at the end to make sure all the speakers get the opportunity to answer the questions if you have anything that you'd like to be further explained. So the next speaker is one of James's colleagues over at UHW. It's Professor Jared Torkington, who's one of the colorectal surgeons at UHW in Cardiff. Jared.
Hi, thanks ever so much, Elise. I'm actually on call today, so I was just contemplating the slightly embarrassing situation where I might have to ignore a consultant connect phone call while speaking, but we'll try and avoid that. I was asked to talk about surgery, and I know that most of you are far too discerning to want to see lots of pictures of operations, but I'm going to talk about surgery a bit at the end. I'm the National Bowel Cancer Lead for Wales, and I'm going to give you a bit of a warts and all a description of where we are with colorectal cancer in Wales, because I think we all have a really important part to play in this. So can I have the next slide, please? So there's an awful lot you can talk about bowel cancer, and I'm going to just give you a bit of an overview about where we are with it in Wales, and I've picked out a couple of little things to speak about. Rapid diagnostic clinics, which I know you're having a talk about in a few weeks' time, screening optimization. I'm also going to talk about robotics, and I'll also talk about the Moondance Cancer Initiative. So colorectal cancer is a really frustrating disease. It's a very rewarding disease to treat because you can cure so many people, but it's very frustrating because a lot of people die who shouldn't die. In Wales every year, there's about 9,000 people die from cancer of some sort. To put that in perspective, we've had 5,000 COVID deaths, 9,000 people die every year from cancer in Wales. Colorectal cancer, there's about 2,000 new cases every year and 1,000 people die every year. And of those 1,000, probably at least 900 didn't have to die, because it's a disease that if we can pick it up early enough, we can cure it. And it's also a disease that actually we understand quite well in many ways. And so in terms of the various types of cancers, if we can't do more in bowel cancer, I wonder sometimes how we can do more in the other bits. So James showed you a graph at the beginning of his talk of how the USC referrals have gone up over the years. I'm just going to show you a couple of things of how COVID has affected what we're doing, given that we weren't doing as well as we could have been before, and this is the COVID effect. So this is the number of pathology samples each week from January to November last year. So on the x-axis is number of weeks, and on the y-axis is the number of pathology sides, so effectively cancer diagnoses. In the light blue is what we were seeing every week. This is just for colorectal cancer in terms of diagnosis in 2019, and in the dark blue line underneath you can see a massive drop-off, which indicates that across Wales there are a lot of people with colorectal cancer out there who we don't know about. In the next slide, please. This is Cardiff and Vale data, and we've collected this and we've submitted this for publication now, and it illustrates two things, none of which will be a surprise to you, but I think it's helpful to see it graphically. On the left-hand side, the number of USC referrals we showed you over several years. This is just what happened last year in comparison to the mean of the 2 years before. So months of the year on the x-axis, y-axis numbers of referrals, and the red line being what we would normally expect, and the blue line being what happened last year. So you can see a massive drop-off in terms of USC referrals, April, May, and then a sort of a backlash on the left-hand graph. And then in terms of what happened with diagnostics for endoscopy, you can see this massive drop-off in April, which has never recovered to its normal level, which is why things like the FIT test have been so important in for us triaging and targeting who should get it. So what's been the knock-on effect on actual numbers of cancers? Come to the next slide, please. Cardiff, I think, probably is slightly different to the rest of Wales, because we have seen probably the same number of cancers as we would expect to see. But what this graph shows is the cumulative number of people with large bowel obstruction, people presenting with emergency presentation of bowel cancer. So on the y-axis is numbers of cases, on the x-axis months of the year. The red line being what we would normally expect over the course of a year. So this is cumulative numbers of cases. And you can see up until December, twice as many patients last year present with bowel obstruction because of delayed diagnosis in Cardiff. This is a real worry. It means more stomas, it means poorer outcomes, and is a real concern. And I think probably Cardiff is not responsible for a lot of those missing cases we saw on those early slides. Patients seem to have come to us eventually, but late. So next slide, please. The frustrating thing about bowel cancer is curable, and this is why we need to work at it right the way across. There's a responsibility for the media, for patients, for primary care, for secondary care. We can do better. We can do so much better if we can get our patients to present earlier. If we can improve screening uptake, we can get quicker, more efficient, and higher yield diagnostics. And actually, the reality is that a lot of our treatments are already very good, but there are things that we can do better, and we can certainly try and improve survivorship, the consequences of living after cancer treatment. So next slide, please. So one of the things that the Welsh Cancer Network is looking at, and there's really a lot of interest at the moment in rapid diagnostic centres or a vague symptom pathway. These for those patients that don't perhaps fit the USC referral guidelines, but those patients that you as general practitioners see and you know are not quite right. And the data out there suggests that GP gut instinct is actually a very good predictor of patients having a cancer. So there were 2 pilots in Wales. One was in Swansea, one was in Cwmtaf, and the Swansea one is the one that's sort of often held up because of 11% cancer yield, or 6% in Cwmtaf. So basically, patients would come to a clinic that have multiple investigations run by general practice in keeping with an MDT from secondary care. So 11% cancer yield in Swansea, 6% in Cwmtaf, although it's important to note that a lot of these were still late stage cancers that were picked up. The other interesting thing, and I think this is where it sort of gets confused between cancer and non-cancer, and there's a lot of other really important diseases out there, is obviously that 35% of patients actually had a non-cancer diagnosis. So vague symptoms, diagnosis unclear, but actually this project led to a diagnosis being made, including things like depression. I know a lot of you from Cardiff and Vale, but not all. We're looking at this now in terms of how it fits for our health board. We're interested in whether there's regional possibilities. Many of you will have heard about the possibility of a new hospital being built. Would a rapid diagnostic centre be on this site, be somewhere else in the health board? What do we do with radiology, which is a very valuable resource, and where that should be? And actually, where the ownership of this is. And at the moment, certainly working with Rachel, we're really keen to support primary care in taking this forward. But you'll hear more, particularly I think from Hilary Wilkes in a few weeks' time, Heather Wilkes in a few weeks' time, about the Swansea pilot. Next slide, please. And so the other thing that I think that's really important to be aware of about in primary care, and you have the opportunity with every patient you see that's over 60 to ask them if they've filled in and returned their screening test. Currently in Wales, it runs from 60 to 74, and every 2 years they're now getting sent a fit test. Our threshold with the FOB test, it was a binary cutoff. It was either positive or it was negative. With fit, as James talked about, you can get a number, and where you put that number determines how many colonoscopies you've got to do and how many cancers you're going to pick up. In Wales, we have set the threshold high. A lot of us feel probably too high. And this means that potentially we miss out on some cancers. So in Wales, it's 150. In England, it's 120. And in Scotland, it's 80. The uptake in Wales is lower than I imagine. When it started about 10 years ago, I thought that we'll see a lot because of close family groups. We'll see uptake will be high in Wales. But in fact, it's stubbornly around 50%. Bowel screening doesn't pick up all the cancers. It picks up about 10%. So only about 200 a year of those 2,000. And it can be better screening. We're behind, not because we're not providing a really high quality service. The quality of the Welsh scheme is probably higher than England, higher than Scotland, dare I say. But we're behind with lowering the age range, which should be coming down to 50. One of the things that's changing in bowel cancer is we're seeing younger and younger people with the disease, and also lowering that fit threshold in order to be able to pick up more cancers. And most of this, if people are brutally honest, is about resource at the moment, and concern about overbearing a system. So just come on at the end now to two quick things to mention to you. One is robotics, and I've been deliberately vague in this slide because we're in the middle of a procurement process. And a bit like any of you have read Lance Armstrong's book, this is not about the robot. We've come up with this really very clever plan to bring robots in across Wales at 4 sites initially, and to use them as a catalyst for change in the cancer flow, right from schools all the way through to media programs, primary care, all the way through, because robots, like it or not, capture people's imaginations. And if we can use them to retain and recruit staff, to get better patient awareness and earlier presentation to primary care with symptoms, and to take some of the fear out of coming to hospital for treatment, then I think then we can start to have a real change in bowel cancer outcomes. So we're using robots not just to give surgeons another fancy toy to play with, but we're going to be very upfront and use it as a marketing tool and a catalyst to try and change some perceptions with the public, with the way they engage with the health service. So finally, my last slide, I just thought I'd mention to you something called the Moondance Cancer Initiative, which was set up purely in the bowel cancer arena 3 years ago now. It was founded by the former owners of Admiral Insurance, who are extremely pro-Welsh and pro-healthcare in Wales, who really wanted to do something about bowel cancer outcomes in Wales. And they charged us with doing something about it, and not funding research and not funding things that the NHS should be doing anything. So we came up with several schemes that we funded from schools, and these are year 7 students in Pontypridd High School. And actually we were really worried about starting to talk to them about cancer, but they absolutely got it, and they got the whole concept of screening. And in fact, what we saw is you know, them getting their this intergenerational health promotion with them, talking to parents and grandparents about sending fit tests back. And we want them, when by the time they come through to screening, to be much more comfortable and cancer to be a lesser taboo subject. And so we did some stuff with Jamie Roberts about promoting screening, and we also funded a Zero to Hero nurse endoscopy program to get more nurses at an accelerated pace through colonoscopy training. They've been so impressed with what they've done that they've now funded a 10-year program looking to expand across a variety of cancer groups. And this is not a closed shop. It's basically looking for the innovative. It's prepared to let people fail and things for not to work. It's not for research, and it's not for funding things the NHS don't do. But if you've got something that you think would improve cancer care, cancer outcomes in Wales, then please get in touch. But I'll leave that there and happy to take any questions later. Thank you.
Oh, thank you very much, Jared. That was really helpful, really honest as well. And you know, I think everyone in the audience was grateful that you didn't have to dash off to an emergency call, but also to all 3 of you in your hospital roles. So very grateful for what you've been doing over the last year in very difficult circumstances. So thank you from primary care. If anyone does need to leave before the end of the session, just to reiterate that if we could have your feedback, please, which will be emailed out if you're not staying till the end, then we can tailor the next sessions to things that you would like to see and hear. So please do fill in any feedback that you receive. Our next speaker is one of my colleagues over at Velindre Cancer Centre in Cardiff, a oncologist treating colorectal cancer there, Professor Richard Adams. Richard.
Thank you very much, Elise, and thank you very much for participating today. And thanks also for James and Jared, who I work very closely with, of sort of leading into this. And I suppose to segue on from that, you know, in terms of Velindre, in terms of cancer care, in terms of what we deliver, yeah, essentially, when we look at colorectal cancer, we only really need to see the patients with late stage 2 or stage 3 or stage 4 cancers. So, you know, the early cancers are dealt with very much by the gastroenterologists and the surgeons. And yet, despite that, and sort of linking in with that problem with screening and early diagnosis, year on year, our referrals go up 3 to 4%, and that's been, you know, non-stop through my life as an oncologist. So there is always that group of patients with later stage disease, which is constantly increasing. And if we can diagnose cancers earlier, I'll get less work to do, which is good. But more importantly, we'll have better outcomes for patients. I think the other thing, I suppose, is linking in a little bit with COVID and trying to deliver things. And certainly in Velindre, we've been attempting to deliver much of our possible in Velindre Cancer Centre, and through the great works of individuals and those that we link with around the healthcare system in Wales, then we've actually managed to keep that going throughout effectively. So I wanted to talk to some things that particularly related to primary care, but maybe took a step back, gave you a little bit of an idea of some of the technical aspects, but without going into excessive detail. I think probably in oncology, we're particularly aware of the fact in terms of our links with primary care is we tend to see people, yes, with a confirmed diagnosis of a cancer. We organise and coordinate some form of treatment for them. And when we start that treatment, our anticipation almost essentially in all of our patients is to give them the treatment where they're in reasonable state, but we're going to give them some treatment based in Velindre as an outpatient, and then we're going to send them home. And we're going to send them home in order to have all their side effects and all their complications. And that's slightly unique in hemato-oncology compared to maybe some of our colleagues, surgery in particular. The surgeons take them in, they're unwell, they look after them until they're better, at least good enough better, and then get them home. Whereas we have a slightly different situation. We're aware that it can add and does add another additional burden to the primary care system. So therefore, close links with us, a better understanding of some of those elements, I think, is hopefully important, but in a very different way to that early diagnosis component. So I'm going to talk a little bit around some sort of curative therapies, some areas where some of our treatments got less complex, which is a good thing, but generally a lot of our treatments, as you can imagine with science, are getting more complex and therefore more challenging with potentially more side effects, and yet are staying in the outpatient setting. And so therefore these patients are in the community. So talk a bit about that, and they're going to talk about some palliative therapy and some important aspects around subdividing colorectal cancers and different therapies that are coming through. And then I'm going to talk a little about pharmacogenomics before we then go on, if there's time, across some simple or common questions really that arise in terms of the community, really, in terms of the after effects of treatment, especially. Next slide. So just do next. So this is just really one of those phenomena, slightly backwards, is that commonly you think about cancers where we're increasingly adding more and more complexity. But this is some data really from the last couple of years, which suggests that when we're treating patients with a stage 3 cancer, so this is after the surgeons have removed the tumor, and we believe there's an advantage in giving some form of chemotherapy, then actually routine care has actually been to deliver that chemotherapy over a 6-month period of time. This is recently data from a big UK study, then an international collaborative, that suggests, in fact, actually you can, in the vast majority of patients, only give them 3 months of chemotherapy, and it's equally effective. So it's nice to see to some degree that we're trying to reduce some of that burden. Next bit of the slide. And I think what the significant bit here, you won't be able to see the specifics, but particularly the types of therapy used in colorectal cancer, and a number of you will see these patients, is one of the long-term consequences in these, quote, cured group of patients is what we call a peripheral sensory neuropathy. And that's one of our particular drugs, oxaliplatin, that can cause permanent damage to the peripheral nerves and result in a loss of sensation, or pins and needles, which can be quite challenging to certain groups of patients. And the strategy of reducing the period of time of the majority of patients on this chemotherapy significantly reduces some of these long-term toxicity problems. And I think that's important for the patients, but also hopefully will reduce some of the burden that you will see in primary care as well. Next slide. Just to sort of iterate some of this, so this sort of thing we look at without you necessarily needing to look at the detail of this, but you can see along the bottom here a spectrum of the different stages of disease that we're treating. A lot of these patients are essentially what are called node-positive disease. So surgeons remove the bowel tumor, we look at that pathologically, look at the size of the tumor, extent through the bowel wall, but then we also look at the lymph nodes that are involved as well. The more lymph nodes that are involved, essentially, the worse the prognosis or the more likely the cancer is to come back. And essentially, the taller grey bars hatching here are essentially what we can achieve by giving surgery alone. And then what oncology does is limited, but it's an extra bonus really in terms of cure rates. And so that the grayer box and then the white and the black boxes are what we add by giving chemotherapy. So if you look at the right-hand side with much more advanced disease, the T4N2 tumor, you can see that essentially there is a poor prognosis in this group of patients, but with appropriate therapy, we are curing a number of these. And if we add chemotherapy to surgery, we can double the rate of cure. We look at the other end of the spectrum on the left-hand side, and the vast majority of the benefit comes from the original surgery. But small additional, and for those individual patients, important aspects around increasing the number of patients who are cured is added by giving chemotherapy. And we can weight, in terms of the different drugs that we use, the likely additional benefits that we can give to those patients by adding in that chemotherapy. And so it's just useful to see why we help with those patients, because it isn't about us dictating to patients what they get, how we decide upon what sorts of therapies we might be giving. And in the vast majority of these patients, now reducing that to 3 months of treatment as opposed to 6 months, which is much better tolerated by a broader group of patients overall. Next slide. This is just another thing that I suppose indicates, or I just want to allude to here using this graph, some of the things that are coming forward. So this is some data that's really come in over the last 1 or 2 years, where actually we're moving to a certain group of patients working with our surgical colleagues more effectively, whereas someone in this situation has a tumor which is diagnosed, then actually in certain situations where that tumor seems slightly more advanced, node positive or slightly larger T stage of tumor or closer to the margins of resection, then actually we're off front prior to surgery. So when you have a patient that you may be seeing and they've been told, yes, they've got a tumor, but they haven't got metastases, and yet they're having chemotherapy and they still haven't had their surgery, well, there are contexts for that, where actually what we're trying to do is improve outcomes by going in with chemotherapy up front and then looking at re-challenging in terms of going back with surgery. And there's certainly increasing evidence in those later but locally advanced stage disease that this actually does improve outcome in terms of survival elements. Next slide. So this, again, complex slide. I didn't want to go into too much detail, but this is another one of these, quote, sort of neoadjuvant strategies, which is more common in bowel cancer. This relates to. So the surgeons will tell you at that time, you know, the complexities around removing a pelvic tumor, a rectal cancer, are very different to removing a colonic tumor. They could both be very challenging, but there are different challenges involved in pelvic tumors because of the anatomy. And so for a number of years now, we've used this for the more advanced rectal tumors, where we give radiotherapy, followed by a period of a break and monitoring, and then re-imaging with a view to then hopefully downsizing the tumor and making surgical cure more feasible by ensuring that we do not leave tumor behind. Now, increasingly, that's coming to the fore as a more and more standard approach. It does depend upon good staging, which we can do effectively with MRI scanning as part of that staging process. The 2 new studies that came out, in fact, during COVID, have actually begun to push us more and more in that direction, and are pushing us more and more in terms of being intensive. So rather than just radiotherapy, which would have been our usual standard, these other strategies are suggesting that what you do up front is give chemotherapy and or radiotherapy, and you give that over some period of time before you then go on to try and remove the primary tumor. And so, although this won't happen with early rectal cancers, this is the sort of thing you may be seeing. Again, a patient who's been told they've not got metastatic disease, but in fact they're having quite prolonged treatment, which may be 3, 4, 5, or 6 months of treatment prior to us then undergoing a curative or attempted curative procedure surgically to try and remove the tumor. Next slide. And I think there's a caveat to this as well. So here's some of the data from those 2 studies that I was indicating on the previous page. The bits I've highlighted in the green boxes bring to the fore a particular area which is of interest to patients and to us in the medical community. And so in those studies, with these new approaches, with enhanced chemotherapy and longer periods of treatment, you could see that these patients went on to surgical resection. And in those what we call interventional new groups, then actually we look at the pathology afterwards and see whether actually there was any tumor contained in what was resected by the surgeons. And you see on the left-hand one, when you look at this strategy called TNT, which is a more aggressive chemotherapy and radiotherapy approach, then actually almost 30% of patients had no tumor left in the specimen removed at surgery. And on the right-hand side, you've got a very similar sort of picture with very similar to 28–30% of patients, again, using a slightly different technique, but again, up to 30% of patients in whom, when you come to surgery, there is no tumor left. And that's sort of bolted on to something that's been growing over the last number of years, where actually there is a group of patients in which what we might call a more definitive approach with chemotherapy and radiotherapy without them proceeding to surgical resection is actually becoming more common in terms of our discussions, and is almost being offered to patients in certain situations. Those very, very advanced tumors, we're much more less likely to do that, but certainly those in which we're still considering the radiotherapy, this can be something that is of consideration. And it can be particularly important for those patients who are more frail, not very frail. It can be a real challenge to deliver some of these treatments, but certainly you don't need to generally be as fit for a more simple radiotherapy approach than you do for surgery. So pelvic surgery can be quite a challenge for patients, obviously. And when you've got a more comorbid or elderly population, then radiotherapy, in terms of our discussions with the patient and our links with the surgeons and oncologists together, actually forms part of that discussion in order to try and optimize strategies for patients. There's also the situation in patients, particularly with lower tumors, where they are likely with surgery to end up with a permanent stoma because the back passage is completely removed without a reanastomosis. That some patients will elect to follow this strategy. Now, it's still a caveat to this strategy, in the sense that this is still only 30% of patients in this scenario. So it's not as good as surgery up front, but it is an option for patients. And if they do get this good response, then consideration of this, what we might call more conservative or active monitoring approach, is very reasonable. But this approach is also very important in terms of those patients who are capable of having quite a tight follow-up. So you want to be able to observe these patients very closely if they don't undergo surgery, with this active monitoring, both with endoscopic evaluation and also with MRI scanning, to ensure that if those patients do recur, then actually salvage surgery with a view to cure. Next slide. So this is the more palliative setting now, and this just gives you an indication of some of the complexity around some of the treatments and algorithms that we've got in terms of the metastatic setting. And without going into any more of that detail, I'll move to the next slide. So this, again, is a little bit more, you understand more and more that our cancers and tumors are being divided by their biology increasingly. And in fact, some of those tumors overlapping, so that we no longer follow the site of origin of the tumor, but the biology becomes more important. And this is where we are in terms of colorectal cancer at the moment. So we divide our tumors into certain mutation types. This phenomenon called RAS-RAF mutant or wild type is important and indicates the use of certain particular drugs that are prone to giving a skin rash, but are quite effective drugs otherwise, generally quite well tolerated. But then you have these other subdivisions, and I'll talk a little bit further about them in a minute as well. Next. On the left hand here, then is another thing, talking slightly about strategies you will see us undertaking with patients with metastatic disease. So this is a curve of a large number of patients from randomized controlled trials, which looks at different approaches. So when somebody has metastatic incurable disease, do you commence treatment and then just keep going and keep going and keep going until either toxicity is too much or until their disease relapses or they die? Or actually, are you better placed to actually give shorter courses of treatment, normally 3 to 4 months of chemotherapy, followed by breaks in treatment, with a plan then to going back onto treatment when the disease starts to grow again? And in fact, this graph suggests that that intermittent strategy is a very reasonable approach for patients. It results in less toxicity, potentially greater quality of life, and actually no detriment in terms of their survival. So this is a strategy that we often use. Next slide. So just briefly looking at a couple of those biologies. So this is a new area that we've come into over the last 6 months. This group of patients who have what we call a BRAF mutation makes about 8% of patients with metastatic disease, so not a large number, but colorectal cancer is a common disease, unfortunately, in terms of cancer terms. So still there's a reasonable number of these patients coming through. And the suggestion is that this novel group of therapies, which are not traditional chemotherapies, these are more targeted therapies attacking the BRAF pathway, are actually quite effective in this group of patients. But actually, we've got different types of side effects arising from these. And particularly here, we're seeing certain types of skin cancers, basal cell carcinomas, squamous cell carcinomas arising in patients on these therapies. And we're keeping an eye on those and referring them through to dermatology. But these are non-curative patients. This is the palliative setting. This relates to some data again from last year, and this is coming into our practice already. This is the use of immunotherapy in colorectal cancer. So you'll have heard about the increasing use of immunotherapies in cancer. In fact, colon cancer is got very few indications currently for immunotherapy. And this group of patients with what we call microsatellite instability makes up, in fact, about 4 or 5% of patients with metastatic disease. But what you can see here is the upper curve is a group of patients who are receiving immunotherapy, and the lower curve is our standard chemotherapy approach, which is deemed in this cancer to be very effective. But you can see the additional benefits of immunotherapy in this group of patients, and this very long tail we see where actually people who do respond to get benefit seem to have a much more prolonged effect of therapy than we would routinely get in our chemotherapy approach. So immunotherapies are coming in and they're coming to the fore. Now, there are concerns, obviously, both in primary care, secondary care, in terms of the impact of immunotherapy. Side effects we particularly are concerned about are autoimmune diseases, which can affect you in very many different ways, and patients can present with slightly peculiar and unusual symptoms. But actually, when we look at the toxicity profiles of this, then in fact, our toxicities and deaths related to treatment from chemotherapy are by far worse than they are with immunotherapy. So whilst we are still living and learning around immunotherapies, it's not actually as big a concern as we might otherwise consider. And referral in with patients with immunotherapies for concerning side effects is something that we're very used to dealing with, and that dialogue with primary care becomes very important. Next slide. So this is just another thing that's come over the last 12 months. So aspects, let's say, linking in with concerns about not resulting in patients having significant toxicities whilst they're at home and then becoming unwell and then needing to be reviewed by primary care and admitted to secondary care is toxicities around chemotherapy. There's a particular drug we use very, very, very frequently in colorectal cancer called 5-FU. It's been around for 50 years, but it's still the mainstay of our treatment. And there's a group of about 6 to 7% of patients who are exquisitely sensitive to it in the sense that they have significant toxicities. And that's to do with an enzyme called DPD. And we, depending on our genetics, and this is our inherited genetics, then we are able to break down 5-FU into a less toxic phenomenon, or we're not able to break it down. And this new gene test is now able to be done across all patients who are going to receive such chemotherapy throughout Wales. We're the first nation to take it on as a full nation. And we managed to introduce this during COVID lockdown because we were concerned that if we could reduce toxicities in patients while continuing treatment, that was a good thing to do. So routinely, these patients have a blood test prior to starting chemotherapy. We get the results back, and in 6 to 7% of patients, it can then inform us to significantly reduce doses and therefore reduce the chances of toxicity. Not eliminate it, but reduce it. Next slide.
Richard, sorry to interrupt. We've just got 5 minutes left now for the session. I know your last two slides, I got them in front of me, are very helpful to community challenges. I wonder if maybe we could share those via email or something with our delegates, because I'm just aware there were a few questions. Was there anything you just quickly wanted to summarise, or you have
No, I think that's good, Lisa. I mean, those questions are very much about the sorts of things that you see in the community in terms of toxicities, and also just about us being an open door. You know, even when we've finished our anti-cancer treatments, being able to come back and communicate with us about challenges with patients. They're not discharged fully and we don't want to see them. We're here to engage and help along with our community palliative care teams.
Oh, thanks ever so much. Fiona, you were manning the questions. Would you like to come in on to our colleagues?
Yes, thank you. And the questions really came from the first two. Sorry, I'll put my video back on. So thinking around fit testing, Rebecca asks, are you aware of a similar process in other health boards in South Wales? So she's working in AB, but the oncology is based in Evelindra. So the pathways, James, that you were discussing, is that how does that work? That's the first question.
Sure. So on a couple of things on that, we have been talking to our colleagues in the other health boards, and everyone's used fit test in slightly different places in their pathway during COVID. And we are actually collating an all Wales fit experience during the COVID pandemic. In Iron Bevan, actually, they were the first to introduce fit into the pathway before COVID. So fit is definitely going to be in every health board's pathway. There may be some slight differences in each health board, depending on how that works for them. But it's been used ubiquitously across Wales already.
Brilliant, thank you. Can GPs request a fit test in a suspected patient, or does the referral need to go to secondary care in order to request the test?
No, so from this new portal, when you actually click the send button, that sends the referral to us and sends the fit test. So it's one button does the two things. Great.
Okay, so that probably answers the next question, which was, so all the fit tests sent from secondary care via the portal, everything, and what happens to the people who don't quite fit the USC criteria?
Yeah, so those patients, they will still be sent the fit test because the computer, the portal, calculates that they're not USC, they're DG30. And then that fit test result will be put on Welsh Clinical Portal. And we have employed a fit coordinator in the health board. And I think, and I can't be quoted on this, I think they will be following those, because those fit test results will be going back to the referrer for action, particularly if they're negative. If they're positive, then the patients will be moved onto the USC pathway.
Brilliant. Okay. Should a recent negative screening fit test affect the management or referral process? If so, how? Is there a longer watch or wait period?
So I think the answer to that is yes, it should definitely. Yeah. I just want to be careful that we don't, we're not falsely reassured by a negative fit. If it's used in the appropriate case, that's fine. But for example, weight loss, we don't want to be using fit testing, because it is only a test that measures hemoglobin in feces, and we will miss pancreatic cancers and renal cell cancer. If the patient has had a negative fit test, then and you still want to refer them, then they could refer rather than a USC, which will make a big difference for us.
Great, thank you. And just very quickly, how's the sample collected? This is the penultimate question. Is it like normal way of collecting a stool sample?
It's slightly different. There's a tiny little cup and also a brush, which you brush along the stool, and it goes into a much more hygienic container. And so I think patients don't feel they're going to the post office and sending a pot of poo back. And so I think that's why it's more tolerated.
Wonderful, thank you. And then the last question is about NICE guidelines. So NICE guidelines suggest USC referral in the over 60s with iron deficiency anemia. Grey area if their ferritin is low and the HB is normal. So not strictly speaking anemic. What any thoughts on this? And that question came up, Jared, during your session.
Yeah, I mean, to me that seems like the perfect place to be using a fit test, actually. I think, just to say quickly, I think fit coordinator has got to be the best job title in the world. I mean, I'm trying desperately hard to apply for the fit doctor post that's going to come up at some point, but I think over the age range. But and one of the things about fit that I think is really important is that it's just another test, and it's still history, still examination, still do lots of tests. So if you see someone who's got a low ferritin and a normal hemoglobin, but you're concerned about them, then a fit test that's a really good place to go. And they would fulfill what James talks about, those gut instinct patients, and we may have rapid diagnostic centres and so on and so forth to pick that up. There's lots of reasons for a low ferritin, as you all know. But
thank you very much. Just a quick request: could the last slide go up, Charlotte? Could we go back to the last slide? And that's all that we've had on the questions. Thank you, people, for your questions. Really important to get this sorted. So back over to you, Elise.
Yeah, well, again, let's finish and get people back to the day jobs. Thank you for your time, and thank you from us to the three speakers today, both to James, Jared, and to Richard. I think some have already left, in fact, to go back to clinic and probably on call bleeps. But yeah, thank you. And any questions, please feel free to get in touch with myself or Fiona. Many thanks.
Thank you.
We welcome evaluation. Thanks all.